Thank you so much for the opportunity to speak here after, like I said, I come here a little battered and bruised up, not from fighting with my surgeons, but after a alpine slide wreck up in Breckenridge, so don't do that. Distal embolization, how to manage. I have no money, feel free to give me some. I've had distal embolizations, and I try to prevent them because it really makes for a long day in the cath lab. So I'm going to show you a couple cases here, and perhaps appropriately to Subhash's statement about common femoral interventions. So I got a 62-year-old who was post-left heart cath at an outside hospital, angioceal to the right common femoral. 2 days later, he presented with these complaints. And you got to be suspect with these calls. I was early in my career during this, and you could see them in a couple weeks, and I kind of made it 1 week. I really missed the urgency there. And this is my baseline aortoiliac angiogram here. I think you can appreciate the common femoral is completely out with a lot of thrombosis. We were able to cross this. Now, again, probably one of the options would have been to just do an endarterectomy, scoop this out, fix it, bovine patch, and be done. We went endovascularly here. We navigated into the profunda, got into the SFA, crossing, and I think you can just see that it's just a disaster here, right? This is just thrombus everywhere. This is before we had ECOS, before we had a really good option for dripping. This is the runoff, and I think it's important for distal embolization more than anything to make certain that you have good runoff and to understand what is your baseline before you know whether or not distal embolization has ever even occurred. So this is your runoff to start off with. You really, really need to make certain that you go all the way down to the foot and take good pictures. So I made some mistakes here, and I think it's always good to learn from other people's mistakes. Number one, I went 7 French instead of 8. The second thing I had to do is to pull the profunda embolic protection device to do rheolytic thrombectomy, because at this point this would be the other option to treat this instead of dripping it. One pass of the DVX angiojet on thrombectomy, and again, this a couple years ago. I think you'll notice something now missing, paucity of flow into the profunda. This does not make for a very good day. Clearly, I'm not a cowboy because I can't lasso thrombus. I tried to lasso this with a 7mm embolic protection device. That didn't capture. I wound up crossing back down through, and then doing pulse spray thrombolysis into the SFA as well as into the profunda. You can see this large thrombus here in the profunda that's kind of hanging out, at which point I wanted to open this up, and so I did balloon angioplasty, 5mm balloon, got good flow, again, treatment here, and then went aggressively after the main problem, which was a dissection caused by the angioceal. I actually did directional atherectomy right to the common femoral itself, which is a little aggressive, but that's how I roll. We then did balloon angioplasty, and you can see here a pretty good result. And then after retrieval of the spider embolic protection device, look what I found. I got thrombus from the turbohawk, and I got the angioceal foot plate out with as well out of the turbohawk as well. So I think that when it comes to distal embolization, prevention is key. Always use protection. And that's all the thrombus that came from the spider EPD. And so I think good judgment comes from experience, and experience comes from bad judgment. And so the next case that came down my road was a 70-year-old with CAD who had severe left rest pain, basically the left lower extremity, absent left CFA pulse. He had failed medical therapy, refused surgery, absolutely was not going to do it after his bypass. You can see he had very low toe pressures on the left-hand side. I also will try to get a CTA if I can for pre-procedural planning. Also told me that there was a lot of calcium in this common femoral. Again, this is an embolic, this is all about distal embolization, so we had to try to figure out what I was dealing with before going in. This is your baseline angiogram. Looking at the left CFA is completely out. Again, refusing surgery, so we were able to cross here using a Pilot 200 coronary technique for the proximal cap and then a stiff angle glide wire for the distal cap. This is with low pressure balloon angioplasty. You can see what you're dealing with. And then having learned from my previous case, I said, all right, we're going in the profunda. We're going to put double embolic protection devices because an ounce of prevention is worth a pound of cure. We're going to prevent this from happening. Did directional atherectomy into the profunda, into the common femoral, and into the SFA. So multiple, being very careful to know where your wires were. You do not want to cut your wire with your turbohawk. Okay, that's even a worse day. So directional atherectomy into both sides. This was before before DCB was available. I used a 7mm balloon, had a little small non-linear dissection. Present on the final angiogram. Velocities, again, almost 3 months later, I did a baseline and then came back, and you can see good velocities. The patient did well. And why I always use embolic protection device with atherectomy is because look at the double filters, debris in both filters, and really the key thing is to try to prevent this from happening more than anything else. So you ask how to treat distal embolization. First thing is don't let it happen. Don't let it happen by understanding what you're up against, be it plaque or be it thrombus. You need to understand what you're up against first and foremost. You really need good baseline angiography to really understand all the way to the foot to see if distal embolization has occurred. You can treat it by aspirating it. You can use export catheters. You can use a multi-purpose catheter. If you guys have not seen this, this was something that was taught to me by David Canzeri, actually. He said just put the wire, 014 wire, right through the hole that's at the end of your MP catheter and use that as a, basically as an aspiration catheter. You can use angiojet, you can use Jetstream, which also is very effective both for the atherectomy, especially if it's thrombus, also for ISR. I particularly like it for Vibon stents that have gone down, as well as thrombus removal. You can destroy it. You can use Jetstream again. You can use laser. You can use TPA with catheter-directed therapy as well. Or you can push it aside with a PTA and with a stent. So I think you have to get rid of it one way or the other. And so the first thing I try to do is, first of all, try to prevent it from happening. And so the EPDs are critical. Embolic protection devices, caveat emptor, not one size doesn't fit all. So with Jetstream, for instance, you can't use a spider filter. You have to use a NAV6, which increases costs because you will get latched onto your wire. You've got to use proper technique. If you're going to use atherectomy of any sort, try not to go too fast. Liberal use of vasodilators, especially if you're using Diamondback or if you're going to plug the microvasculature. That's really distal embolization as well. Recognize those higher risk lesions. So I presented two cases here. Here, one with thrombus, one with exophytic plaque, very calcific plaque, which is absolutely going to go down. If you have those boulder fields of thrombus or plaque, pardon me, those kind of popcorn calcifications, those love to embolize. I've actually had one clog my filter and then couldn't get the filter out. So it does happen. If it does occur, you basically try to suck it out, destroy it, push it aside with a balloon and or stented. And really the key thing here is you need really good baseline pictures to understand whether or not you've actually had distal embolization. Every single time, if it's aortoiliac, if it's SFA, if it's anything, always take the pictures all the way to the foot to start off with and then at the end. And sometimes it's good to try to cross through and take those baseline pictures right off the bat with a third order angiography in the popliteal so you really get some good pictures to understand what you're up against. But you need to have those good baseline pictures. Thanks so much.